leading to reduction in airway resistance. And down the line, it eventually helps with dilation of the terminal airways, whereby improving gas exchange. With this improvement in FRC and lung compliance, the patient's or the baby's workable breathing is improved. This helps reducing periods of apnea. And another great thing is that while being on CPAP, it helps promote lung growth in premature infants. Next slide. Yeah. So the delivery of CPAP is affected by a few factors. It's dependent on the seal and the resistance of the nasal interface. It depends on the flow of the system. Of course, depending on how the baby mouth is. If it's open, there might be loss of pressure. So that affects how the CPAP is delivered and received by the patient. And certainly the anatomical and physiological resistance of the airways of the baby may affect how a CPAP is given. Next slide. So the types of interface is important. So with occlusive CPAP, it's where we utilize the mask or the binasal prongs, and it's they need to be in a correct fit, meaning that those prongs need to be occlusive, filling up the nares, because that will help maintain the pressure and the flow within the system. But at the same time, we need to keep in mind that whenever we make things as occlusive, there's a lot of pressure points and could potentially cause pressure injury. And so we need to be mindful about leaving a gap between the septum as well as the interface. If we're using the mask needs to be a little snug to make sure we don't have any leakage, but at the same time, we can't let it be too tight or else it'll cause further injury near the nasal septum. And then next one, Kathy. And then with non-occlusive CPAP, those are things like the RAM or NeoFlow. So it's an open system, and so it cannot be completely occlusive because it needs some leeway to allow the air to leak out to provide a little expiratory phase. And so ideally, we want the nares, the cannulae, to be filling about 80-ish% of the nares. That way we provide maximum CPAP delivery, but allowing enough space for the air to leak out. Next slide. So here are the main occlusive CPAPs that you will see. So usually you'll either see the scuba or the snorkel. The scuba is on the left. So I think this is generally what we use in our community, NICUs and at the main. So this is with the Fisher Paykel. They'll have both the prongs and mask. And on the right, you have kind of the snorkel system. So traditionally, these were the Hudson prongs. I guess there are new prongs called the Babby prongs that have come out and that some places like Stanford are utilizing. But when we talk about putting babies on occlusive CPAP, these are the type of devices that we're talking about. But as you can see, it looks very cumbersome. It seems to be not comfortable looking. And so sometimes that, and a lot of times you can't even see a baby's face. And so, but it has its benefits, and that's something we'll be talking about today. Next slide. And here's a non-occlusive CPAP. So there's two major non-occlusive CPAP devices, the RAM cannula and the NeoFlow. And you can kind of see, it looks like a glorified high flow nasal cannula, but look how comfortable the baby's looking. It's very easy to put on, and you can see so much of the face. So it's a very, it makes parents much happier. And a lot of times, especially seeing them comfortable, just brings a smile to parents' faces. Next slide, Kathy.
So I think Rich maybe read a little bit into those pictures, but as we said, we'll talk into that later. And also, Rich doesn't give himself enough for his alkaloids. honestly has plenty. So, and what I'm going to talk to here is the continuous flow CPAP, which is what we use. We don't use bubble CPAP, but we use the ventilator CPAP. And so, as you guys know, and probably used to seeing, the infant ventilator is set to a CPAP, which is shown by the blue arrow. And then the pressure itself is delivered by varying resistance to exhalation at the exhalation valve, or that yellow arrow. And that's how you adjust the CPAP. So again, we dial in the blue arrow, and what we want to get out is kind of that yellow arrow. And there's various things that can make that yellow arrow change. Now with a bubble CPAP, what's actually going to happen is you actually set the flow, and then your PEEP is going to be around where you would want it, but more up and down, versus again, here on the ventilator, you're going to set your PEEP, and then your flow is going to vary to give you whatever kind of that PEEP is there. Now, the continuous flow CPAP for the occlusive CPAP devices or interfaces has a separate inspiratory and expiratory limb, as you guys can see here in this picture. The inspiratory limb brings in warm and humidified gases. And then the expiratory limb is how you adjust the CPAP, like we just talked about, whether it's machine or bubble, as well as allowing for gas exchange, which is really important. You want to get rid of that carbon dioxide, so it allows you to be able to breathe out and get rid of that. As you guys can note here, both inspiratory and expiratory are large diameter, lower resistance tubing. Now for the non-occlusive or RAM cannula and NeoFlow cannulas, there is a Y connector so that the two ends of the inspiratory and expiratory tubing, which you guys can see at the very top part of here, then connect into the RAM cannula. And then there's this long tube that goes all the way to the nose to provide you the RAM cannula. So this is a different setup. There is no separate expiratory limb. So there is the risk that in trying to breathe out or get that carbon dioxide out and get it through this long tubing all the way back through all that tubing to there, you could accumulate carbon dioxide if you have occlusive fitting prongs, which is why the manufacturer of the RAM and NeoFlow, as well as the literature and what we've been educated on, is that these cannulas cannot be occlusive. They must be non-occlusive, which is why we talk to 80% kind of being that max, because they do need a leak around the prongs for expiration or exhalation of gas. And now if your mouth was open, potentially you could get some of that out, but that's not always guaranteed. For example, if the baby's sucking on a pacifier, you're just not going to see that. So that's why we talk to having non-occlusive prongs with a nasal CPAP non-occlusive. Now these devices, the occlusive ones that we've been talking about, are essentially class 2 medical devices, or the CPAP interfaces, and they must meet performance standards to gain approval. The RAM cannula or other types of such, imagine the NeoFlow, is a class 1 medical device, so it does not require performance standards for approval. And in fact, if you actually look at the NeoTech, who makes the RAM cannula, their website, they list it as a nasal oxygen cannula for use with low to high flow humidified oxygen. So this is what it is labeled for. It is not FDA approved or labeled for actual use with CPAP. And so, Rich, I think we'll go into why do we use then the RAM cannula for CPAP? And you can even see, note in this picture with this baby, he's kind of raising his hands like, why? I don't know, he's shrugging. He's kind of going over why.
Well, yes, but I also look at the same picture and then I see that, baby looks so comfortable. And, once again, it's also, if we're providing the same kind of respiratory support, I just want to be there for the parents. So it's the parents with all that real estate that's on the face, I think it provides some level of comfort. And also, I know you mentioned that, it's not FDA approved, but as you can imagine, many things what we do in neonatology is not FDA approved. And so it's about using what we have to do what's best for the baby. But I'm sure Kathy will soon mention there's a lot of studies with a lot of scientific mumbo jumbo about resistance this, pressure that, lung model this. But I like to keep things simple. If it's easier for the staff to put on the CPAP device, as well as provide good respiratory support and also keep parents happy, I think that's a good way for me to go about providing respiratory support for these kiddos. But I think the biggest reason is going to be nasal injury. The Fisher group, they kind of observed their practice, and then they saw that on kiddos that are on CPAP, about 40% of them had some level of nasal injury. And the Nzegu group, they had an observational QI study where they kind of looked at the kids that was on conventional with also RAM's CPAP. And they said the most common reason that their patients were switched over to the RAM was because of nasal breakdown. And you kind of see pictures on the right here along the septum, how there's irritation on the lower right. There's like some ulceration right below. And then, so certainly we have all experienced nasal septum breakdown. And sometimes we had to involve even like plastic surgeons because of just how aggressive these injuries have progressed to. And but the group also mentioned that once they switched the babies over to the RAM cannula, there was no further breakdown of the nasal septum or nasal area. And after switching over, a lot of this concurrent injury resolved within a week or so. So that is very reassuring. And once again, parents, they're going to be very devastated when they see their kids going through injury like this. And it's very obvious because the face is one of the first things that parents will see when they come in to see their baby. Next slide. Let's see, I think it was also the Dracher group. I think they also mentioned, if you look down here, they looked at their kids, whether they were on the conventional versus the RAM group. In the red box there, they looked at skin and mucosal breakdown. And then in the control conventional interface, about 53% of them had some type of breakdown, whereas about 8% was found in the RAM group, and it was statistically significant. Next slide.
So again, back to the question, why do we use the RAM cannula for CPAP? So I think obviously Rich made his point that yes, it is off-label use, and we do use a lot of things that are off-label in the NICU. And a lot of sites and people, and even Rich had kind of mentioned it, it's just for perceived ease of use. It's a cannula, it does look a lot easier to fit on compared to the other CPAP devices. Although to note, you still do need to have that cannula in the nose. There's many times I go by the bedside and it's not. But that is ease of use there. And then of course, less nasal injury. And that is what has been described in the literature. And I know that Denise has said that at our own institution, we do see more with the Fisher and Paykel system compared to the RAM. Now, the RAM itself, it's labeled as a softer material, thinner walled prongs, obviously less nasal injury, easier, as well as they're saying that there's larger nasal prong inner diameters resulting in lower airflow resistance. So ideally, wow, this maybe should give you a better flow overall. But what we're finding, and what I'll describe right now, is that there's actually suboptimal pressures delivered in comparison with occlusion devices. And some of that may come to that long tubing we saw in that picture way back when with the green, where it's very small diameter, very long, high resistance, and we're not quite getting the pressures that we dial in. And so again, not meant or approved as a CPAP device. So should we still keep using it? So let's talk to some of the studies. So one of these studies was done in India in published in 2020. And their goal was to look at delivered descending pressures in the oropharynx and preterm infants on bubble CPAP on 3 different nasal interfaces. Their initial goal with this was they wanted this randomized controlled trial to compare clinical outcomes, so actually look at the babies over time with the Hudson or occlusive prongs versus the RAM cannula. And why are they doing this? Because like we've talked about, they realize that the type of interface is one of the most important factors influencing your pressure with the nasal CPAP. So if you really want to give CPAP, really focus on that interface. The ultimate goal was that their ethics committee said, no, we can't let you do that, but we are going to allow you to do in vivo pressure monitoring of these 2 interfaces, as well as we're going to add in a Drager nasal mask. And we're going to use mean pharyngeal pressures to measure it because they were concerned after reading the literature about delivered pressure with the RAM cannula. So they allowed 30 preterm infants with respiratory distress for each of the 3 interfaces. They were randomized. And the mean gestational age was about 31 weeks or so, mean birth weight about 13, 10. It could range anywhere from 28 to 34 weeks. So a slightly older population. And then with the methods, they did use the cannulate for the RAM cannula to note. Caveat though, they said later that they should not have done that, that the manufacturer says it should not be occlusive, and this can make the RAM cannula occlusive, that we need to not use the cannulate with it. But they did try to shoot for more 80% occlusive with the RAM cannula. The mouth was not actively closed, so maybe typically what we would see with the baby opening and closing. And the CPAP and FiO2 were adjusted per infant need. So if the infant needed a little bit more, they gave more, but ultimately you couldn't go past 6 or you couldn't go past an FiO2 of 30%. So it was pretty low, it was about 5 or 6. And then they used a pressure monitoring transducer to measure oral pharyngeal pressure for 30 to 40 readings or 2 to 3 minutes between 24 and 48 hours postnatal age, and then an average was taken. What they found was that the delivered oral pharyngeal pressures with these 3 interfaces, 5 to 6, was not exactly what they dialed in. And you can see across for, let's see, 5 here, you have 5 and then RAM, Hudson, and mask. And it's in order of how much pressure they deliver. So RAM the least, Hudson the next, and then mask the next. So ultimately, when they looked at all the different averages, they said, okay, well, out of all the devices, which ones were about 0.5 off? And over half of them were at least 0.5 off. I mean, as you can see here, the mask was actually only delivering 4.5 when we dialed in 5, and when we dialed in 6, it only delivered 5.5. So overall, the RAM never was always 0.5 off. The Hudson prongs about 3/4 of the time, the mask 60%. And then if you look at anything that was greater than 1 centimeter off, the RAM was greater than 1 centimeter off about 2/3 of the time. The Hudson less so, maybe 1/3, and the mask actually only 3% did really well. So what they found with this study was that none of the nasal interfaces delivered the oropharyngeal pressure equivalent to nasal CPAP, RAM the least, and the nasal mask delivered the best matched CPAP pressure, thinking that, hey, without those prongs, there's probably actually less resistance or negligible resistance or near absence of leaks at the nose. So maybe this mask actually isn't such a bad thing. Then the study in Australia, in Melbourne, published in 2019, looked at assessment of resistance of nasal CPAP interfaces. And the reason they did this, again, is that CPAP is becoming more popular, as we all know, and recommended over intubation, but there hadn't really been any specific recommendations on what choice of CPAP system or which interface. And they said, again, it's very important. We realize that efficacy of CPAP is really dependent on effective pressure delivery, and many factors influence that, including the interface. So they looked at actually a lot, 4 short binasal prongs and 2 nasal masks with 3 sizes of each interface. And as you guys can see here, they actually had a kind of different model where they checked the inspiratory limb and checked the flow, went to the nasal interface, and then had the expiratory limb where they knocked it off there and then essentially checked the pressure that was coming through that. They did 3 different flows. They did 6, 8, and 10 liters, which we'll see in the next slide. So here, again, we'll start kind of explaining this slide from top to bottom. So you have the 2 different masks up here, and then you have the 4 different prongs, a lot of which we use here, Fisher and Paykel and RAM. And then over here, from top to bottom, you're going to have the flows 10, 8, 6, 10, 8, 6. And then again, if you look over here at the mask, you're going to have the largest mask size going down to the small. So it's always going to start with the largest going down to the small prong or mask. And then what they did over here is, again, they measured that expiratory limb pressure with the idea of how much pressure is built up, kind of like a resistance, meaning it hinders your flow. You're not going to get as much flow. Overall, as you guys can see here, it looks like the mask actually had pretty low resistance, kind of what we saw in the last study. It looked pretty darn good. And these prongs here, the infant flow prong, wow, looks amazing. Actually reached out to Denise and said, where's this infant flow prong? Unfortunately, though, I think it is now obsolete. They don't even make the device to connect it to the ventilator. So we have what we have now, which is our Fisher and Paykel, the RAM and the Hudson. And as we can see here, ultimately, when you look at the larger prongs, so for the bigger babies, they have less resistance, and that makes sense. Smaller prongs are probably going to have more resistance. And then when you look at the higher flows, almost across the board, the higher flows actually have more resistance. They don't actually help. They don't give more air, and then you get better pressure. They actually give more resistance. And you know, across the board for the RAM, the Fisher and Paykel, and the Hudson, you do see that there's a lot of resistance at the very small sizes. So with the really micro preemies or preemies, it's going to be hard. They're not delivering maybe as well as you would like, especially at the higher flows. It then gets better for Fisher and Paykel and Hudson with the larger sizes prongs, but with the RAM, it's pretty much just low all the way across, which probably goes to the fact that it's not just the prongs, but it's, again, that long tubing system that goes back all the way to connect to the ventilator. So conclusion from this was that nasal CPAP masks have lower intrinsic resistance than short binasal prongs, which we've now seen in 2 different studies. Resistance is higher with smaller prong sizes and higher gas flows, and varies considerably between devices. So again, important to know your device. The RAM cannula has a high resistance at all SS sizes. And ultimately, you may need a correction factor to get past that resistance and deliver that pressure that you want based on which interface you're using and the pressure and the flows. So knowing like, hey, I'm going to use a ram cannula, I'm probably going to need a higher PEEP to get that target pressure that I wanted because there's a lot more resistance involved. Now, this study was done 2014-16, around that time, at Children's Hospital of Philadelphia. They looked at occlusive versus RAM CPAP and open versus closed mouth. And that's why you see these two graphs here, mouth fully closed, mouth fully open. And just to describe this graph, they looked at the occlusive CPAP being the Draeger prongs. They had two different sizes, and then they had the three different sizes of the RAM, the micro preemie, the preemie, and the infant. In this particular graph, you're going to see the preemie, but pretty much all of the different graphs for micro preemie, preemie, and infant looked the same. So I'm just going to show you one. The Nary's internal diameter, they created a model or mannequin based physiologically off of what a typical Nary's and septum looked like for 1 to 3 kilo kid. And they came out with 4 or 5 different sizes. And that's what they measured these 3 different RAM cannulas against, with the idea that, hey, let's see here, your Nary's diameter, you have a 3 Nary's diameter. So a smaller diameter nose, and you put in this preemie cannula, you're 100% occlusive, it's a lot more occlusive, versus with the bigger Nary's, you're going to get less occlusive. And they really wanted to look at that because, again, we're supposed to be, if you remember, 60 to 80% for the RAM non-occlusive. So they set this CPAP anywhere from 4, 5, 6, 7, 8. And then over here, you're going to see what pressure is delivered. And what we see here is obviously with the Draeger, pretty much the pressure that you dialed in is the pressure that you delivered when it is 100% occlusive. And that's with your mouth fully closed. Now, if you have the RAM 100% occlusive, also closed, but then with mouth fully closed, that 100% occlusive, you wouldn't be able to exhale. Again, it's not meant to be 100% occlusive, nor should it ever be. But here, 60 to 80%, you see that when you dial in, this is what's recommended, when you dial in, let's say 8, you only get about 5.5. Same thing with the 60%. If you dial in 8, you're really only getting about 2.3, and even less so with the less occlusive. So again, it's not really giving you the PEEP that you dial in. So just to note, and then again, mouth fully open, wow, the pressure's just dropped dramatically. So another reason why sometimes when babies really need that CPAP, that distending pressure, we talk about using chin strap, we talk about using pacifier, putting the hands up to keep the mouth closed. So in conclusion, the traditional CPAP interface, the complete Nary seals, deliver NAP at or above the set pressures versus the RAM cannula with partial nasal occlusion in the recommended 60 to 80% range, deliver MAPs, which are on average 60% lower than the intended CPAP level. Now, there was another study, and this was actually done by a respiratory therapist in Akron, Ohio, and they looked at the effective flow and interface on bubble CPAP pressures. And as you guys know, we've talked about, CPAP is dependent on flow and interface. And they evaluated 2 interfaces, 2 sizes of the RAM cannula. I think it was the preemie and the infant, and then our newborn, and then 1 size of the Fisher and Paykel prongs. And they used different flows for each one, because again, remember with bubble CPAP, you set the flow and then your pressure can vary, although they did have goal set pressures or PEEPs with that too. And they used a simulated lung model. Now, their thought was that, hey, maybe if we increase flow, we'll be able to compensate for an air leak. Like, you know, with the RAM cannula, it's not as, it's air leak around it, it's only 80% occlusive, but if we increase flow, things will get better, we'll fix it. And what they actually found was that measured CPAP levels were lower than set across all CPAPs and flows, kind of like what we have been seeing, RAM more so than Fisher and Paykel, which again is consistent with all the studies we've talked about. And that increasing flow can actually cause more turbulence in smaller airways and interfaces, leading to more resistance. So again, going back to that increasing flow we saw in the other graph, it doesn't necessarily help. So if you think, wow, like, oh, we're having a problem, we're not getting the PEEP, let's just increase the flow, it may actually hinder or hurt you and your effort to help the baby than help. And it all goes back to actually just helping to fix that interface and making it the best it can be. And then finally, RAM cannula has been looked at with NIPPV2, and that's something we use it for, which you guys have seen. So in Canada in 2015, they published in the Journal of Perinatology this study where they wanted to look at short binasal prongs versus RAM, and then the carbon dioxide exhalation, the tidal volumes, and some of the pressures that were given with that. And so they did this study, it was a mannequin kind of thing, or a different setup system with that. And again, here in this particular part of it, you're going to see that with the NIPPV, and we'll talk more to that this time than the CPAP they have there, but the NIPPV, with its increasing pressures, they wanted to see how much carbon dioxide remained in the lung. Meaning as you get lower, if you have lower here, meaning you're exhaling more carbon dioxide. So with increasing pressures, it seems like you're exhaling more carbon dioxide. And that short binasal prong with increasing pressures actually seems to be doing a lot better job at getting that carbon dioxide out than the RAM does. So what they found here is that carbon dioxide elimination is directly proportional to PIP, as well as liver tidal volume, and it does seem like the interface matters. And then they said, you know what, let's also measure the pressure at the actual ventilator, because they had a ventilator attached to it there. And so they had the set PIP on the ventilator, and they said, let's see what the measured PIP on the ventilator then is. And here's your RAM on top, and there's your short binasal prongs, which are the Fisher and Paykel. And they found that when you dial in, let's say 14, you really only got 10 and 5 here. So lower, you didn't always get the pressure you dialed in, as we imagine, we kind of talked about. But they were interested. They're like, wow, the RAM actually did better. There's a higher measured PIP. Why is that? And so then they looked at the resistance of the different interfaces, and they found that, wow, short binasal prongs have a lot more resistance than RAM. So maybe it's back to the resistance. Maybe there's a lot of resistance there, and that's what we're seeing actually measured there with that long tubing going all the way back to the vent. And so they said, you know what really matters is what pressures are we getting to the lung? So let's look at that. And so they have pressures, as you can see here, set PIPs on the ventilator and the pressures to the lung. As you note here, they are a lot lower. They said they're significantly reduced, but ultimately what you're seeing here is that the short binasal prongs did a lot better than the RAM and actually delivered some type of pressure there compared to the RAM. So ultimately they thought, you know what, in this system, we think what's happening is we're getting the pressure to the lungs, we're getting the carbon dioxide out better with the short binasal prongs, which is ideally what we want to do. But the RAM, it actually looks like deceptively better on the ventilator because you have so much resistance feeding back. When it's actually doing the job, it's not doing as good a job as we think it is. So again, the interface of choice does affect the efficacy of NIPPV. And finally, one last study here from 2019, they had 14 subjects in this particular one where they monitored at NIPPV, and they looked at ventilator supported breaths, so both the patient and the vent breathing. Then they looked at just the patient breathing, the unsupported breaths, and then they looked at that, just the ventilator breathing. And they were able to tell if the baby was breathing or not with the use of NAVA, where you can tell the diaphragm excursion and if they're breathing. And they compared this using the RAM cannula to see how effective the RAM was. They did use pacifiers, chin straps, or mouth positioning as needed, like we would. They monitored the baby for 15 minutes. They used current NIPPV settings, did not change that. Whatever the baby was on, they kept it. And there you'll see the PEEP, the PIPs, the rates, the high times. And the mean at birth was around, gestational age was around 27 weeks, 900 grams. But when they actually did the study, it was probably about 4 or 5 weeks later, 32 weeks, 1472 grams. And what they found was that mean tidal volumes with these ventilator-only inflations were much lower. But infants seem to do better with spontaneous efforts, meaning whatever we set in the vent, if the vent only was breathing, it didn't do a great job. The baby was breathing, potentially breathing in bigger breath, breathing over maybe that resistance from the RAM, they did better. So they said, again, this NIPPV or tidal volume delivery is really affected by the resistance of the RAM and maybe doesn't deliver what we think it delivers. So let's see. Show you guys real quick a view of this, and then I'll have Rich go and we'll skip maybe the other video later. Let me see if I can pull this up. This is a Fisher and Paykel video that was shown to us a few, let's see. Sorry, there was shown to us last year when we did some respiratory education. And he'll kind of talk to.
So let me show you what that looks like. So I plug in the expiratory limb. I plug in the inspiratory limb. I go ahead and I turn on my flow. Let me bring it down to 8 liters of flow real quick. I've got a neat little machine over here that does this. And now when you look at it, take a look, you see those vibrations that are going across. And that is because that's basically the nature of bubble CPAP. The air, water goes in, or the air goes in the water bubbles, and that causes a vibration. And so you see a range of plus or minus 1 or 2 centimeters of water pressure. This here is the lung of the baby. So what I can do is I can simulate what it would look like when the baby exhales. So let's take a look at that flow. You could see it going up a little bit up and down, but the mean stays the same. It stays at 5 centimeters of water pressure. So there's not a lot of effect within there as they breathe against it. That's because there is this bias flow, and you have a relatively short Y piece right there that allows the baby to exhale with that. Now, what would happen to my system if the baby was a mouth breather? So I'm going to go ahead and take out this pacifier, and you'll notice I'm still getting a little bit of bubbles, but look how much the CPAP has dropped. It's dropped from 5 centimeters of water pressure all the way down to 2 centimeters of water pressure. And you'll say, well, I still see a little bit bubbles, but the CPAP that the baby is getting is reduced dramatically. So that's why a lot of people will use chin straps, or they'll use a pacifier, or they'll go ahead and what you guys do, which I think is awesome, is put the fist underneath the chin and hold the baby's mouth shut. Okay, so that's what an occlusive interface looks like when it's on a baby. I know this baby is not alive, but all things being equal, meaning we're going to have the same baby here, let's go ahead and plug in a cannula. Now, I don't have any RAM cannulas with me. I'm going to try to get some so that we can see what that looks like when it's put into effect. But I have a premature cannula, and I have an infant cannula. So this one's a little bit larger. So let's see what these guys look like when I go on baby. Give me a second here. And you guys use this Y adapter whenever you guys do CPAP on a cannula. So I plug that on, and I'm going to go ahead and take off this interface. There we go. Pop it out the nose. Take the bonnet off. Okay, let's go with the small one first. So I would say the occlusion rate on this one is probably about 50%, maybe a little bit less. So what does that do to the CPAP when you're doing a small occlusion? I'm going to hold that back up. So the CPAP that we're getting right now is about 1 centimeter water pressure. So by simply just moving from a non-occlusive or an occlusive CPAP to a non-occlusive, you get a dramatic reduction. But take a look at what happens at the work of breathing. So when I press the work of breathing, you can see there is a really acute or a distinct wavelength where the baby is exhaling and breathing against that. The explanation for that is relatively simple. It's just you have a very long tubing that they breathe against when it comes back to this Y piece back here. And so you do get an increase of work of breathing when you do that. I love cannulas. This is not to take cannulas down. It's just to demonstrate what they look like based on specific therapies and stuff.
Okay, so we'll go back to it. And he next shows in the rest part of that slide there, he shows it actually with a larger cannula, so maybe more 80% occlusive, because if you remember that one was 50% occlusive, and he says that it really only gives you maybe up from 1 to 2 of CPAP. So it gives you kind of a little minimal with the same resistance that he was talking to. So we'll go back to the slides. So essentially that to me was kind of just going over a summary of what we were all talking about right now. And so in my case, I feel like I've rested my case that there is for Rich, just so he knows that he can feel the burn. And I think Rich is now going to take over on his part.
So as you can imagine, there's a lot of information, literature showing that RAM is just not quite as good as occlusive CPAP. So the question remains, why are we still using it? Is occlusive the answer? But all I kept hearing was that there's measuring of pressure. We're using a lung mannequin, a lung model, but in reality, majority of the studies that Kathy has shared is not real life setting. But in fact, there's not a lot of great studies out there comparing RAM CPAP versus occlusive CPAP head to head. That's well done. A lot of it is some observational studies or QI. But keeping all in mind what Kathy has presented, it was a little daunting that there was not much in my favor, because I tend to favor the non-occlusive CPAP. And, but we try to practice as best evidence-based medicine as possible. So it was a little daunting for me. So it was to the point where, Kathy's sharing all this data to me, and I'm just like, well, maybe I should just switch over to her side. And I was just like, well, is there anything else that I could help, present? And it was honestly almost last minute finding of this paper, but it is the most recent, and I feel it's the best research that's study that's out there comparing binasal CPAP versus RAM. And so the next slide, Kathy. So there's this group in Israel, the Hoshwell group. So they actually had a prospective study comparing the use of RAM CPAP versus binasal short prongs. And then it was not a, it is a technically a multi-center, albeit 2 centers, but it was randomized, non-blinded, because if it was blinded, it'd be virtually impossible without covering the baby's face. But they were going to look at a couple of things. The primary outcome was looking at the need for intubation within 72 hours of starting CPAP, or looking at is there significant nasal trauma enough to change the nasal interface. And then I know you've seen a lot of us utilizing the Ensure or LISA for giving surfactant, and they did not consider those to be intubations. And secondarily, they took a look at nasal trauma, and also you could see at the bottom that they had a couple of other secondary outcomes. Their hypothesis was that they looked at the same data that Kathy looked at, and they felt that, you know what, RAM CPAP is not going to do quite as well as the binasal short prongs. Next slide. So actually they had a pretty good patient population. So they wound up getting about 166 patients eligible to be randomized, and 83 in each arm. 83, so the CLNT is essentially the RAM cannula, and the SPM would be the binasal. And so even if you break down the allocation of the patient, a good number of them were in the small category, meaning less than 1,250 grams, because there's always that concern of, you know, would the RAM cannula be beneficial for the smaller babies? And then for some of those babies, and depending on which arm that you're at, they actually had a good stretch of a good allocation of babies that was on the nasal IMV as initial treatment versus did they just get extubated and they got placed on the nasal IMV. So they had a good breakdown of allocation for their patient population. Next slide. And actually, and then when they looked at the groups in each arm, they were quite similar. The mean gestational age for each arm was about 29 weeks, and they had as babies as small as 24 weekers. Mean birth weight was about 1,250 grams on each side. And you can see kind of like the range. They've had babies as small as 500 grams. So it's good real clinical medicine patient population characteristics that we're seeing. And I was really happy to see in this study that a good portion of them, about 50% of them, was a low birth weight, being less than 1,250 grams. And the great thing I even saw that if you look all the way on the bottom, they kind of describe what the clinical status of the baby was prior to being on the nasal IMV. And so their FiO2 needs, their last recorded CO2, and then the last pH on the gas, they were all very similar. So it's not like one patient population was sicker than the other. Next slide. So to the group's surprise, looking at the primary outcome, looking at the total study group, this is looking at what's the percentage of these patients that need to get intubated within 72 hours. Nothing was statistically different. Now, if you look at the 95% confidence interval, since this is absolute difference, if it crosses a 0, that range, that means it's not statistically significant. Same thing as with that p-value, anything greater than 0.05 is not statistically significant. And so between the RAM cannula and the classic short binasal prongs, they essentially statistically had the same percentage of patients needing to get reintubated. That means in total, and whether they broke it down by birth weight, it all seems to be very consistent. So since they're not statistically significant, what that means is that the RAM cannula is non-inferior to the short binasal prongs or masks, which doesn't, but I'm not here to say that it is better from a respiratory support standpoint, but it is just as good. And so that was little bit reassuring for me to see that, especially considering Kathy provided all this data that it was the opposite. The next slide. Looking at the secondary outcomes, honestly, there was nothing else different between the two patient populations, other than the obvious fact of, yes, if we were on the RAM cannula, there was less nasal trauma, which is pretty consistent through throughout the literature. The interesting thing I did find is that we all, I think, when we have kids on RAM cannula, we essentially add 1 or 2 extra centimeters of water trying to get the same pressure that you would get with the occlusive. But if you look at the nasal IMV settings, they are essentially equal. It's almost the same amount of PEEP and FiO2 and respiratory rate settings that have been set for each side, which was surprising to me because I tend to, I think all of us tend to give extra pressures when we're on the RAM cannula. But once again, primary outcome, statistically, they're the same, so not inferior, but also the outcomes wise, it didn't seem to be worse or any better, other than the nasal trauma. Next slide. So what does this all mean? Honestly, it's, there's a lot of research that seems to be supportive of what Kathy's trying to show. There's studies that say that non-occlusive can be just as good. And then, what I think about it is that sometimes research the physics physical breakdown of the pulmonology into the physics of like resistance, flow. Sometimes it doesn't translate to the real world. I think if anything, what this shows, just like in most things in neonatology, there's like 5 billion ways to do something to treat that baby, to treat that infection, or to, in this case, provide respiratory support. I think that this is just more evidence to show that if you're working in a unit that does things a specific way, take advantage of that, standardize that, and do that well, because probably you're able to provide just as good using one way versus another.
Yeah, and I echo what Rich said. Essentially, whatever you do, do it good. Although to note, Rich, in your study, I think the mean gestational age was 29 weeks. So, I mean, they're younger kids, but 29 weeks, just kidding. But anyway, honestly, what Rich said, I think we're back to the point that whatever you do, do it good. I mean, know your devices. As you guys have learned, and what we're hopefully have taught you in this study is that there's lots of different interfaces. There's going to be more. There'll be more and more coming out, but it's not, who knows, maybe one will be better than the other. At this point, it's really using what you know good. And so really know your device, know how to use it, know its limitations, know its benefits, and hopefully that will help us all as a team. And talking about that too, teamwork is really a big player here. And ultimately in any NICU that does really well with BPD and such, and taking care of these kids, it's really that teamwork. And that's not only from you guys as respiratory therapists with these devices, but also for our nurses at the bedside to kind of know the devices, know when they need to call you guys, know when maybe it's not working, how to troubleshoot, know when to call the physician. Same thing for us as physicians. We too, and nurse practitioners, should know these devices, should know, when we should use them, when's a good time to use them, when's to back away, when's to troubleshoot, what we need to do with them. So again, like we talked about, again, more than just the machine, it's more than the interface. It's really all about educating all of us at the bedside to be able to take better care of this. And then we'll bypass this right now, just to be able to get to questions and us to give our own viewpoints. But ultimately, this video is of Dr. Wong and Columbia University in New York City. They were one of the early adopters of nasal CPAP, and they did it so well, they still have one of the lower BPD rates in the country, and they use the occlusive or Hudson prongs. So they talk to the fact of how to use those prongs, and really importantly, how important teamwork is, especially even at the beginning of resuscitation. And they'll show in this video, and I'll give you the minutes if you guys want to look at it later, where to go to, but kind of how everyone, like 4 or 5 different people are involved, and they put those prongs in and they keep them there. They never let the baby lose the FRC or that PEEP while everyone else is doing everything else around the baby, putting the pulse ox, putting the heart monitors, all of that. So very important, that teamwork. And we really want to stress that. But personal preference, as you guys know, you've heard about Rich's Chicago Bears, and then mine is personally the Kansas City Chiefs, which I can't really say that I'm smiling a lot with them this year, but anyway, I'll let Rich go over his personal preference, and then I can give mine.
I guess I kind of start off with, how is the kid looking? I think the work of breathing tends to play a huge role whether I'm going to go with RAM CPAP versus Fisher-Paykel. But definitely the second big thing would be the size of the kiddo. If it's a big kid, almost always will go to the RAM CPAP. I think bigger the kid, they're a lot more active, and I think they just look uncomfortable being on the Fisher-Paykel. And I think that looking at my cutoff where I would consider trending towards using the occlusive CPAP more, it's probably right around that 1,250 gram or 29-30 week is my cutoff. So below that, I would kind of be looking at, okay, I would consider Fisher-Paykel. But once again, I look at the work of breathing. If the kid looks just like very comfortable, I think I might even with I've used RAM CPAP with good success in 1,000, 1,100 grammars. But it also depends on how the baby's looking. If the baby is the same size but is struggling to breathe, I might be looking to do Fisher-Paykel just to kind of provide a different interface that might provide better or different support. Just because I am on RAM CPAP doesn't mean I am married to it. So I am totally open to switching over to Fisher-Paykel. But first, it's all about, we've all heard about that's not, RAM CPAP is not providing as much pressure compared to occlusive, but a lot of people are PEEP phobic. And so a lot of people look at the numbers of the high PEEPs that you might see on the ventilator and they're like, oh my goodness. But I try to look at the baby, listen to the baby as I go up on the PEEP. Am I getting better air entry? And as I maximize my PEEP on the RAM cannula and not getting much success, I will switch over to Fisher-Paykel to see if that would provide better support. And also, it's also about respecting our colleagues. And just because I'm coming on service after Kathy, there is no way that means that I'm just going to switch things over to the RAM cannula because the baby is doing well. Why mess with something that's working? Every baby's a little bit different. Some babies like the Fisher-Paykel better. Some babies like the RAM cannula better. But I won't necessarily switch over to RAM cannula following a person who's inclined to use the Fisher-Paykel. I certainly, the other thing I would say that I would probably lean more towards using the Fisher-Paykel more is if I have an LGAN or ELBW and I've extubated them. I think good nasal IMV, good FRC is the way to provide good extubation success. So for those small babies, if I'm extubating them, I probably would put them on nasal IMV while on the Fisher-Paykel.
Okay. Yeah, that's great. And so some of those are going to echo Rich, and then some obviously my personal preference. But again, Denise mentioned I trained Baylor College of Medicine, Texas Children's in Houston, and there we were users of occlusive CPAP in the Hudson Province. And so that's what I trained with. We kept those babies on until about 32 or 34 weeks. We didn't even let them off CPAP. We weren't big believers at the time in high flow. We were more believers in kind of that whole idea of, like we talked about earlier, the physiology of CPAP and helping the lungs to grow better, growing those alveoli, overall just getting better growth because you're supporting the baby better. And I think currently they have actually switched now from Hudson to just the Fisher-Paykel mask, actually, talking about the mask with less resistance, and they do still keep them on till 32 weeks. Now, I've also had the benefit, and one of the things that's good is seeing other units and what they do. And so I've seen also the RAM cannula use and its use in babies on my former practice now here. And I think in looking at all the different times I've seen it, I will say that there are times that I think, yes, you can put the baby on the RAM or non-occlusive, and you can put the baby on occlusive. I've definitely felt like I've seen kids struggle a little bit more sometimes with that non-occlusive versus not the occlusive in the same situation. And some of that may have been helped if we had known maybe to give more pressures or give higher pressures, again, knowing the resistance and patterns of the RAM cannula and the non-occlusive. And then I think sometimes too, in those kids that are struggling, maybe they have more apnea, so you ultimately go up on caffeine. They have more apnea, so people do sepsis workups, although a lot of times I'm not always positive. If you overlooked at their overall growth, how are they growing? And that may have been something to look at in that study that Rich last presented. So that's just kind of my own personal experience with it. And so ultimately, yeah, I think in babies who really need that PEEP, that FRC, I'll always go with the Fisher and Paykel first, especially in the elbows or very low birth weights initially. And then more so, in term infants, if you have a term infant who's really struggling or really working to breathe, maybe just to get that FRC open until a little bit more stable. And then, like Rich said, I think they are a little bit more comfortable once you do switch them over to the RAM. Now, all that being said, I have seen pressure injuries with the Hudson. We had plenty of them where I trained. So I've definitely seen that as compared to the Ram. So that is one benefit of the Ram there. But, you know, and watching the Fisher and Paykel rep demo and talk to things and hearing Dr. Wong at Columbia talk, it's really about knowing your device, kind of like we've gone back to, and really putting it in the right position so you don't have those pressure injuries, and working with it to that best of its ability. And I think at Rancho, we've really done some training on it in the past year. And whereas before, a year ago, I wasn't as comfortable using the Fisher and Paykel mask, I really feel a lot more comfortable using it now, just with that practice and education we've had on it. So I know when to use occlusive versus non-occlusive. This is kind of what Rich and I came up with. Rich, are you still there?
I am. Thank you for stopping. I just want to thank everybody for allowing me to be here. I just need to step off for another Zoom. I apologize, but Kathy will pass along those questions to me. So please ask great questions, please. Thank you very much.
Okay. And I'll just give, this is our last slide, kind of the advice that we had here. So again, this is kind of what we came up with. So from both of us agree that with occlusive, you know, on admit when trying to obtain an FRC, like we talked about the PEEP, and stabilize an infant with more moderate to severe respiratory distress, we would definitely recommend the occlusive. And elbows are very low birth weight babies. And that could be, you know, Rich talked to 1250, which is probably about right. Sometimes 1500 from birth until stronger, more stable, probably start with the occlusive. And then again, when they're stronger, more stable, which could be a few days to weeks to month, maybe use that. And then non-occlusive, if you're in that point where you're like, oh, the baby is well enough, but we're debating on high flow or CPAP, maybe you could use that RAM CPAP because it'll give you maybe more of that set CPAP. Again, elbow or very low birth weight that is stable and current support, more active, good growth, few apneas and good respiratory drive, probably an okay time to use that RAM. And then again, Rich and I both talked to increasing your PEEP, again, knowing your device and the resistance. So if you are going to use the RAM and you want to use that CPAP, knowing that probably with the RAM, you're going to have to give a higher PEEP or CPAP compared to the occlusive because it's not going to give you the same. And so that's what we've recommended there. And again, kind of like Rich said, we are a team and we do want to work together, and hopefully knowing this will help us keep the best, I guess, respiratory support for our babies based off what they need. And so these are our references. And then we are definitely open to questions, as well as I think I'll show this last slide. I know Denise wanted to go over that QR code for you guys.
So Kathy, there's no questions so far in the chat box there, but there was a note from Liz, and she wanted to state 2 points. Being on RAM is more convenient for procedures like the LISA or Ensure, and it can be used at the same time for those. And then Rady's policy says occlusive is recommended for neonates less than 1,500 grams.
Okay, that's great. I'm glad that Lizbeth brought that up. That's good. And I actually have, I know we've definitely done the RAM with Lisa. The past 2 Lisas I've done have been with the Fisher and Paykel system, and it worked well. We got it in on the first time.
Oh, you were able to do it with the Fisher Paykel, didn't get in the way?
No, I didn't. Yeah, I think Skip was there one time. I can't remember if it was Yesenia, if it was you the other time, but yeah, it was able to work. I mean, definitely probably a little bit more cumbersome like you're talking about, but yeah, we were able to get it to work.
That's awesome.
I've only done it with the RAM with Dr. Fernandez. He usually has them on the NIV, and we, you know, are able to bump up the pressures and bump up the FiO2.
Nice.
And they're basically, we're doing it concurrently. They're getting the LISA while they're on the NIV through the RAM.
Yeah,
it seems to work pretty well. But I was wondering if you would even be able to intubate, you know, with that big contraption on the nose.
You can. It's not as easy as doing it with the RAM, but you definitely can.
Yeah.
Okay.
And I've done it too. And some of the Lisa, and you know, I'd have to pull up the videos that I've seen them do it with the different occlusive devices, because ultimately a lot of these kids that need it, maybe those elbows or really small birth weight babies that are on that occlusive anyway to begin with. And then that being said, I mean, if you use the RAM like we talked about, you can always, kind of like you said, you go up on FiO2, or you know, maybe even more importantly, go up on the pressures just to support the baby during that time. But yeah, both I've seen done.
That's good to know.
Yeah, I think we're slowly getting more comfortable with the Lisa. I know all of us it's somewhat new, but I really like it. I think it's great for the babies.
Any other questions for Kathy? I did have one, Kathy. On the slide that you had with the RAM and NIPPV study, I was wondering what % of occlusion of the RAM did they utilize?
Oh, yes, I forgot to mention that. So they said they did it according to the manufacturer's recommendations, which I'm guessing they probably went with about 80% occlusion for the RAM and tried to shoot for full occlusion with their Fisher and Paykel.
Great, thank you.
Mm-hmm.
Any more questions for Dr. Weiss? Anybody now a strong believer in the RAM that wasn't, or a strong believer in occlusive when you liked the RAM before?
I just think I have better success with the RAM myself. Less breakdown, and the kids seem to do a lot better in my experience.
Yeah, and again, we all have our personal as to what to use and such. So yeah, again, everyone I think feels certain things work the way they do. And I think too, again, for us, the pressure injuries, and I know we've worked on that with Scripps La Jolla, now at Rancho too, just knowing our devices better helps a lot with a lot of those occlusive devices, because they are slightly more cumbersome. Although I think maybe ultimately, as you guys have seen, they probably deliver the PEEP better, the FRC overall better when you dial in what you want to dial in. And different units have had to fight with those pressure. I know at Stanford, and Rich talked to, they were using now the Babby prongs, and they actually had the Columbia team come and teach them and educate them on it to make sure that they were putting it at the proper place to limit those pressure injuries, to give the proper PEEP, just to make sure they were giving the best CPAP possible without causing any pressure injuries. Other places have used kind of the mask, and I've heard that in time they've had problems with the Fisher and Paykel mask causing problems at the top of the nose or in the areas there. What they found is that it was that pressure was putting too much pressure back, was pulling back on those on that mask because it was too heavy at the end. So again, it's just knowing that device, knowing how to not make it heavy, how to set up your device better. But yeah, again, RAM I think is a little bit easier to set up, and ultimately if you can get a good PEEP and a baby who can use it, it can definitely be used.
So Kathy, we did have a message from Sarah Casperino that says she likes both of them for different situations. And then a question from Skip. He wants to know if we should start with the occlusive mask now, based on your data, where before we were always saying start with the prongs.
Yes.
And then there was another comment from whoever's on the phone number 6435. Either way they both work, so it depends on the physician's preference. And Monique said, I think it's like you said before, knowing the device really helps. And Evelyn Medina said, occlusive seems better to deliver the PEEP better, and the RAM seems aesthetically better as long as the work of breathing is lesser. So do you want to address Skip's question?
Yeah, and all great statements. I completely agree with those last ones. And then, yeah, the mask. So, actually, the more I read about it, yes, the more having seen these studies. And Rich and I were actually just at a conference on children's hospitals, and one of them was talking about how they've preferentially now used the mask because of those studies showing less resistance, and that the babies are getting more of that delivered, that pressure. So yeah, it kind of makes me think maybe it's not a bad idea to start getting better at the mask and use it more, especially for those elbows where, gosh, when you look at that one graph, the resistance, and it is really low compared to those prongs, the small micropreemie prongs, which can have a higher resistance. So it may not be a bad idea just to get more education or more practice on that mask for when, those units that are getting those small babies, I think it'd be of benefit.
I know that's something that Gretchen, the NICU educator here at Rady, Maine, and I have discussed several times, because before they didn't have those super small prongs, right? Like they didn't even make them, and you had to use the mask. And then they came out with those very, very small prongs, and we've both agreed those have way too much resistance. I don't know why they think that they're beneficial over the mask, other than, we need to rotate for skin protection, but they have a very high resistance.
Yeah, no, I agree. I mean, it seems like it almost more hinder than not. And yeah, you're right. I think I remember some of our units trying to fit initially the prongs in, these small babies, 400, 500 grammars, and it didn't really work, but the mask did. And yeah, maybe it's good because maybe we do need those masks for those smaller babies.
One thing I've noticed with the Dragers when we use the mask, I feel like, well, the Drager doesn't allow a lot of fluctuation of pressure, and so you get a lot of alarms with the mask. And I don't like to crank the mask down on the baby's face. I mean, even with using the Mepilex, you know, I don't want to. I feel like I'm having to just kind of crump it down a little bit more if I want to keep the alarm from making the nurses crazy and be able to actually wear that mask for 4 to 6 hours. Sometimes I've had to literally give up, and which is frustrating because obviously the mask provides better CPAP. So I don't know. Does anybody know of a way that the alarms can be adjusted on the Drager when we're using that modality? Because I haven't figured that one out.
Liz, we have the Drager representative coming to your next skills fair, so we'll ask Alicia then.
That would be perfect.
Yeah, I was going to say maybe asking the rep, and that could be something. Actually, I know Skip and I were reaching out to Ryan Selby, the Fisher and Paykel rep, about the use of phototherapy goggles with their Fisher and Paykel system to make that the best possible system without disrupting the hat or any of the other respiratory component of it. And so maybe what we could do is ask him to kind of give a demo or talk about that, because you're right, Liz, I've seen that kind of off and on with the mask. And I think that was always what I saw initially. It was very frustrating to me because I also wanted to get good at the mask, and it seemed like that would go off and on. And you're right, we had to tie it down a little bit tighter, it seemed like, which is never good. You want it to just kind of rest on the nose. I know some of the things we did the other day, we maybe switched the size and it got slightly better with that. Putting in that extra foam piece, a little stuff like that. But even then, I think it's beneficial maybe to have Ryan Selby kind of come and talk to that again, just to see maybe how we're fitting the mask. I think that'd be helpful.
Are there any other questions for Kathy? Okay, has everybody had a chance to do the QR code? Is there anybody that still needs the QR code? Skip is asking if we can get other sizes. Are those of the masks, Skip? Because we only have 3 size masks. We have 4 sizes of Fisher and Paykel prongs that should be on your Omnicell. If they're not, we'll get you the 4th size. We also have the 4 smallest size prongs that should be on your Omnicell. Then we skip a size because the septal difference is the same as the next size up, so we pick the one with the bigger septal difference. And those ones are pretty good for your meconium aspiration kids. And those, hats, more hat sizes too. Okay. We should have all the right size hats. I will check with you next time I come to Rancho and we'll look. But you should have all the right size hats on your Omni.
Denise, hi, it's Jane.
Hi, Jane.
Hi. So I wrote that comment about the hats. I think we only have 2 sizes of hats, do we not? And sometimes those straps, like in order to make it the right size, those straps, like we pull them all the way back. And like,
Wow.
It's the more
There should be 5 size hats available in every Omnicell. Should not be 2. Should be 5 sizes of hats. And then we also have this giant headgear that you can use on a meconium aspiration baby that every nursery's nurse manager was supposed to have ordered a couple of them. I know I've seen them at Hillcrest. I know I've seen them at La Jolla. They're in the bins. I think Skip has them up at Rancho. they're pretty cumbersome. So if you can fit a hat on them, it's a lot easier to use than that. But for those big meconium kids who might need a little CPAP, or they might just do better on the RAM, because that thing is pretty cumbersome.
Okay. Yeah, I'll have to double check. Thank you.
Yeah. Okay, does anybody need more time with the QR code?
When we get the certificate, will mine doesn't have my name or license number on it. Is it supposed to?
Nope, you just write in your name and license number on it. The one that will be here at Maine, the record of it, if they were to audit you, we'll have your name, the information will be there.
Okay, great, thanks.
Mm-hmm. Okay, well, I think we're done for today. Thank you very much, Kathy, and tell Richard that I said thank you very much. I think you guys did a wonderful job, and I really enjoyed the camaraderie and the friendly bantering.
Good, good. Hopefully. Yeah, it was fun. And thanks for the great questions, guys. And of course, you know, like Rich said, I can pass those along. We're always open to questions. Feel free.
All right. Thank you so much.